we'll do that. So I wanted to welcome you all. Thank you very much for attending this webinar on our course, Fundamentals of Digital Health. My name's Professor Dragan Ilic. I'm the Deputy Head of the School of Public Health and Preventive Medicine here at Monash University in Australia. I oversee the education portfolio, and we've got a wonderful 55 odd minutes planned for you today. A wonderful panel chaired by Professor Ian Rouse, who's a professor here at our school. We've got a wonderful panel set up that you can see from left to right. We've got Benjamin Schmidt, who is the Head of Research and Collaboration at Siemens Healthineers, Professor Shah Yassin, who's the Head of the School of Medicine, Nursing and Health Sciences at Monash University, Malaysia, and Associate Professor and General Practitioner, Dr. Maitri Gunatilake, who's an Associate Professor here at Monash University, a General Practitioner, and also has done some fabulous work internationally through his NGO, Possible Dreams International. Ian, I'm going to hand over to you, and we'll welcome any questions that participants may have. Feel free to use the Q&A down the bottom, and we'll look forward to a lively discussion. Ian, over to yourself.
Okay, thanks very much, Dragan. I can say it's a real pleasure to welcome all of you to this webinar on fundamentals of digital health, and perhaps with a focus on some of the emerging challenges in the digital health space. Without a question, I think from my point of view, probably everybody who's in this webinar, you can see that the world of healthcare has made significant changes in the past decade. I'm not a clinician, but I guess I can see what's been happening in the world of healthcare. The growing impact of technology on healthcare is going to continue at pace in the future, and I'd say at rapid speed, and Benjamin will be able to tell us about that for sure. We've got data, we've got big data, we've got data repositories, clinical support systems, electronic health records and electronic medical records. I could go on and on. The current landscape is rapidly developing. Someone I've known for some time, Ian Buchan, used to talk about the tsunami of information, which isn't yet controlled by what he called the blizzard of different systems, and then the drought of enough skilled data analysts to make use of all the information that's been collected. But then we can roll in biomarkers and wearables and AI and augmented intelligence, if I can use that rather than AI. Numerous innovations in things like robots and drones and the Internet of Things and precision medicine. But then there's, what about people? Like I say, what about people and regulatory bodies and data security and the management of healthcare, and the dream maybe that developing technologies can help everybody wherever they happen to be. If anyone's a movie follower, I almost thought that maybe we're in a space of everything, everywhere, all at once. Because, you know, I can't keep up. I don't know how clinicians keep up with what's happening, but I certainly find it difficult to just keep up with what's happening. So it's really exciting for me to welcome three distinguished speakers who can share their experience and perspectives on what's happening in the digital health area. Professor Yassin is the head of the Jeffrey Cheer School of Medicine and Health Sciences at Monash University, Malaysia. In terms of this webinar, Professor Yassin has a significant experience over a long career in different aspects of delivery of healthcare, which I think is really important. And then we have Associate Professor Gunatilake, is an Australian medical doctor, Social Professor of Global Health, and when I've heard him talk before, he's got a long interest in how do we ensure that what we can deliver in healthcare can be delivered to all parts of the world in which we live. And then Dr. Benjamin Schmidt, who we've heard once before in one of our webinars, comes with a long experience in what I might call the developing period of digital health. Certainly in one of the world leaders, which is Siemens Healthineers. That's a company which clearly has had a long-standing, almost pioneering role in engineering and healthcare and what can happen. And Benjamin comes from a background as a physicist, I believe, and an imaging scientist, but is now working as a head of research and clinical translation in the Asia Pacific area. So as Dragan's indicated, I've asked each of the presenters to talk for about 10 minutes, up to about 10 minutes, either with PowerPoints or just talk. And then we'll open up for a webinar questions. And I think you've already indicated, Dragon, if you want to post questions into the chat box, we can certainly pick them up when we get to the plenary session. So with that brief introduction, pleasure for me to hand over to Professor Yassin to kick us off with his experience or thoughts about where we are with digital health.
Okay. I'm not down here is morning. We are at about 9 o'clock in this morning here in Malaysia. So so I have an interest in sort of health systems, and I have been working like Maitri in a general practice environment for many years before getting into education. So you know, in both those areas, you can see things changing. In education, there's a massive transition, especially during the COVID. It literally forced things on us when everybody was locked down. And you can see things, those things opening up, you do feel that things will never be the same. You know, a major sort of a issue like that has forced us to change in a significant way. Now, almost half our sessions, teaching sessions are online, you know, and a lot of what we thought we couldn't teach online because we have to have lectures, we have to have face-to-face sessions, is all being done online. And the advantages of it is slowly coming through. There are, of course, not everything is positive. There are one or two things which could be difficult when you do it online. But in general, there are a lot more, seems to be a lot more positives than negatives. And like all new sort of changes and innovations, especially in relation to IT, people only talk about the problems first. The advantages and the becomes more, comes across a few years, sometimes a few months, few years later. The benefits of it sort of flows through much slower. So in a way, healthcare hasn't had that massive level of transition, even though during the COVID period, we were all stuck at home. You know, there was issues where illness was, you know, hospitals were, there's papers and publications which seems to suggest that people were getting less heart attacks, less serious illness during the period of lockdowns, and hospitals were less busy, except during the period of COVID, during the worst periods of COVID. But other aspects and other illnesses were actually less serious, less common, less admissions and all that. But healthcare, to a large extent, has been very difficult to sort of change. There's been the disruption which has happened in so many other areas, which is related to IT and technology, hasn't quite sort of percolated into the healthcare systems as much as we like. There are lots of things around, you know, hospitals have taken on IT systems and health management systems, but it hasn't really sort of done as much as for example, if you look at, you know, obvious things like online shopping, you know, taxis, for example, you know, those sort of kind of things has had quite a huge change in the last 5 years. But healthcare has still been a problem. There's still a huge amount of discrepancies. Access issues are still a major problem. People are, and the differentials in health metrics across the world is still a major problem. And within the country, like in Malaysia, for example, and Southeast Asia, for example, there's huge discrepancies in healthcare access as well as outcomes in urban as opposed to rural areas, in well-to-do as opposed to less well-to-do, marginalized populations, indigenous populations in Malaysia, as in Australia, is similarly quite significantly major problems. So as I see, one of the big things which has sort of has sort of resulted in a lack of major disruption in healthcare is things like, there's this common constant sense that there is security of systems, privacy issues, confidentiality issues, and then there's issues about access to technology, and then challenges in integration. We still have huge integration issues between sort of primary care and hospital care, and from primary care to sort of allied health cares and all that. So why isn't this things happening? Why aren't we in the sort of so many areas you see globalization aspects, which has resulted in sort of integration in so many aspects, and has resulted in reduction in cost and sort of standardization of standards and quality, but not so much in healthcare. You still have a problem there. So I think I would like to sort of discuss some of those things in perhaps during the discussion period. But there so many aspects of IT and integration and technology has been happening in sort of in isolation. We all talk about biomarkers. We had some discussions of biomarkers last year even, and how that has gone in and become sort of so common. Or we have everything from watches to monitoring devices on people. We have remote monitoring. So much more can be done now. We have telehealth, and of course, the most important and recent is, of course, the AI. One of the big issues has been the fact that there has been a differential in power between patients and healthcare practitioners, and that is now being broken down. And I can see that within the next few years, especially with AI coming in, things like ChatGPT and GPT-4 and all that, you can actually go and get much better information in a much more sort of organized and summarized fashion. Whereas previously, you go to a doctor's office, they will say that, you got all this information from Google. That's not really very good. So you need to sort of, watch out. But now with AI, I mean, we're not saying it's there yet, but I don't see very long when it all becomes much better. You can actually go in, as Ian had indicated, things like individual aspects of your own health with precision medicine and all those sort of things. You actually can go and find out about yourself much better, much quicker through AI, once it really becomes much more reliable. At this stage, it is still has got some kinks in it, but I think once it gets there, we will actually, I think there's probably a time when the disruption is going to happen. I mean, we have been saying that for 15 years. So let's not completely be able to predict the future, So, but I can feel that some of these aspects which are happening will finally likely to bring things together and make people much more sort of, able to take control of their own healthcare and able to get information which no single healthcare or a group of healthcare practitioners will be able to sort of fully control. So I think with that, I'll probably stop because I think there's others may.
Perfect. Thanks very much, Sharon. You've touched on a number of things which I'm sure can raise questions in the discussion. But let's move on now to Professor Gunatuleke, and maybe a slightly different perspective, but over to you to give us either share your presentation or tell us about what you think about the challenges in digital health.
Thank you so much, and thank you, Shah, for that really enlightening discussion. I'm completely in agreement with what Shah's talking about, and my perspective is also from a health systems perspective. I've been a clinician for 17 years. Feels like a long time, and I've been working at that interface between public health and clinical medicine. So I might just, I do have some slides which I'll try and share. Can you see anything? Let's see, okay. Can you see my presentation there? Is that, or is it not showing?
We can see your screen. It says
you
launch.
can see
We're
You
seeing
can't
the
see
browser.
that. Okay, that's it's good that we're doing it on digital health so that we can see some of the pitfalls. Okay, I'll try again.
Martha, if it's easier, I can.
Oh, if you don't mind, Dragon, if you've got it there, that'd be fabulous.
Yeah, no problem. If you can just.
You got to unshare first, I think.
I'm sure, yeah.
Yeah. Fantastic. And there you go.
Beautiful. So if we go to just that first slide, Dragon, over the last 17 years that I've been working in the clinical space, I've seen our clinical world be entirely transformed. So a few of the spaces I work in Australia, I'm the chief medical officer at a men's prison for 1,000 inmates in a sort of a rural part of Victoria. And one of the problems with correctional medicine is that when a prisoner enters the system, they don't just, they're not a static entity in one prison. It's not Shawshank Redemption. It's actually a very dynamic process, and they will enter a reception prison and then they'll often move many times during their sentence. From a healthcare perspective, that presents a lot of intuitive difficulties around continuity of care. And so a digital medical record, which we call J-Care or Justice Care in Victoria, over the last 3 or 4 years has been rolled out. And it was, prior to that, we used to just have, as we did in every clinic, just big folders of paper. And you can imagine in this kind of context, it was incredibly imperfect, because you would find that a prisoner would go from one prison to the other, and the next day they would be missing all their medications, or they'd be missing the really important parts of their history. So that has actually been really useful, as well as the integration of telehealth into our specialist referral services. That has been really helpful, especially for prisoners who, for whatever reason, don't want to go to the one prison in Melbourne where they can receive referral support from St Vincent's Hospital. And so that has also meant significant advances in terms of the health of our prison population in Australia. I also work, and where I am currently is a rural clinic in the hills of East Gippsland. And we have a small 3,000 patient population here and 3 doctors. And what we have faced as rural clinicians is this problem with trying to get our patients in to see specialists because of workforce shortages. And telehealth has absolutely transformed that. We've also been able to have these in the last few years, the apps on our phone have become so much more advanced that we have access to all the latest therapeutic guidelines. And some of these guidelines are incredibly advanced. For some of my Aboriginal patients that I see, we have, for example, ear infection guidelines, which have messages for families in simple language in different Aboriginal languages. And you can actually press on a particular button and it will play that message in that language. So it's actually, even in the last 12 or 18 months, our accessibility to digital tools which can actually improve our clinical care has continued to further increase. Now, The other space which I work, which Dragan and Ian alluded to, and if you go to the next slide, is in low-income settings in global health. And if you go to the next one, in my final year of medicine 17 years ago, or 18 years ago, I went to a place called Eswatini in the south of Africa, which is a tiny little country with the highest prevalence of HIV/AIDS in the world, where 1 in 4 people are HIV positive, and it continues to have that highest prevalence. This is a country which is very different to Australia in many ways, not least of which is that it is not a democratic country. It is ruled by an autocratic king, and because of a lot of socio-political factors and the influence of HIV, this country has a very high proportion of people who live rurally, 80% of the population, and of them, 2/3 live under less than $1.25 a day. Now, that is what World Bank defines as living in extreme poverty. So you can imagine that immediately there are some massive issues that we have with access to healthcare and with the social determinants of health. And what I thought I'd talk about briefly was, firstly, about some of the innovations which we've seen in Africa and in low-income countries recently digitally, but then to just briefly mention what we call the digital determinants of health and how they might be impacting access to digital resources. So if you go to the next slide, Dragan, so this is our NGO is set up in the Lubombo Mountains of Eswatini and services 32 rural communities, providing sort of integrated solutions for people living in extreme poverty and HIV. And if you go to the next slide, some of the digital innovations that we've seen, this is an app made by a mate of mine who is an ophthalmologist in South Africa, and he made an app which allows people to, GPs or not GPs, just healthcare workers, to take a photograph of a cataract and send it digitally in real time to a specialist in South Africa or in the center of Swaziland, and they can provide real-time feedback about what that patient needs. Cataract blindness is one of the big killers in sub-Saharan Africa, because if you can imagine, if you're living in poverty in a rural area and you can't see where you're going, there's a lot of problems that ends up with, everything from being bitten by snakes to falling in holes and breaking bones. So that's been transformative. If you go to the next slide, this app has been disseminated throughout the southern African region and has been really taken up very well. If you go to the next one, this is called iCow. It's an app for it's actually like a veterinary midwife in an app, which will, for so many people living in rural Africa who are agrarian farmers, they get access to expert information about how to make their crops and their farms and their livestock more sustainable. If you go to the next slide, this is called eNable, which is a network of digital humanitarian volunteers around the world who are providing access to their 3D printers to print prosthetic limbs and other things for people in low-income countries. Just extraordinary. If you go to the next slide, and then I just wanted to finish with this, which is the big question, which is what we're facing in low-income settings, is who has access to these digital innovations and to digital health capacity. If you go to the next slide, there's been some talk about the digital determinants of health, not only just accessing digital resources, but also who has digital health literacy, and also the penetration of broadband into communities and the integration of digital health into sort of community infrastructure. If you go to the next slide, This is, and to the next. The TANAHASHI framework is just a useful framework of looking at health access, and it talks about, resources. In order to have access to resources, it needs to be there, it needs to be available, it needs to be accessible both financially and physically, and then it needs to be acceptable to the community, and then also there needs to be in place some kind of system to follow that up. So in order for it to be effective. And if you go to the last slide, just talk briefly about what some of those access barriers to digital health might be, including everything from who has access to it, but also does disinformation get in the way? Is it are you digitally health literate, and how do we follow this up with providers who are who can actually continue to perpetuate these systems? So yeah, that's what I wanted to talk just briefly about today, and perhaps we can elaborate in the plenary.
Fantastic, thanks very much. Yeah, I think and some of the questions or some of the issues you've raised there are things that I had questions. And how do we, with all the significant developments in digital health, how do we ensure that it reaches everybody? Now that's a real challenge. But with that brief comment, I'm going to hand over to Benjamin, who's been working in a company that's made significant advances in the application of technology. So over to you, Benjamin, to hear your side of the story about the challenges of digital health. Go ahead.
Yes. Thank you, Ian, and thank you, Ian and Dragan, for the warm welcome and the flattering words. So yes, my talk's gonna take a slightly different angle. I think Shah and Maitri discussed some very important points about the democratization and the things that are coming up. Yeah. So while this option space that falls under digital health is extremely large, and I think what OpenAI has been doing with large language models has blown this right open, right? The imagination of what can be done with these kind of technologies. And there's a lot of complex topics, and everyone keeps talking about digital and data and AI and all these things. But at the end of the day, I've had a recent cancer case in the family. And when you then bring it down to accessibility of data, just everything looks like a broken record. Still nowadays, you float between specialists and public health, and nothing really talks. And it's very different in order to provide an optimal level of care with this broken record situation. So looking at this from a vendor's perspective, or from a innovative company's perspective, for us, it's very much about boiling it down to how can we enable our customers, which are normally healthcare professionals, to deliver these services in a digitally enabled world to their patients. So we don't normally trade directly with patients, but we see that our customers have the patient need to leverage a highly digitalized patient experience. So I'm going to share a few slides with you on how we go about doing this. So presenter view. Righto. So I hope you can all see my screen. If I get a thumbs up. Yep. Perfect. Right. So what are we dealing with? We're dealing with an aging population, and we're dealing generally worldwide with a shortage of physicians. So can we have digital solutions that effectively address this this issue that we're facing? More patients needing healthcare, less physicians to render healthcare. But then we are creating all this data, right? As we are going through digitization of records, we're creating all this data, but then there's more digital data available, but how do we go through it, right? There's a small percentage which is absolutely crucial, and it's a matter of coming to these crucial data points and bringing those together, really. How are we connecting patients and the care providers? How are we communicating results to the patient? And this is, again, about the democratization of healthcare, right? How are they, what is the digital literacy? So, and these are all topics that we as a manufacturer need to look at in order to end up with solutions that are actually meaningful. So when we look at the hospital value chain, how the hospital creates value for the patient, we deal a lot in medical imaging. We also do laboratory diagnostics. We also do therapy business, radiation therapy. But a lot of it evolves around the imaging value chain, because images and data that are derived off of images or lab data, they keep coming back into the treatment realm. So when we look at this imaging value chain, right, we can identify points in the chain that are repeating themselves. So how do we bring this all together and make it usable? We're talking radiology data, we're talking cardiology data, we're talking pathology data, right? So these are all these diagnostic data that form part of a patient's treatment, like Maitri mentioned before, right? The image of the cataract, right? So this is all basically coming together, but it should be forming part of a patient's record in order to be utilized downstream and in a repeated fashion. So we use a technique called design thinking, yeah. And the design thinking essentially means that we focus on people, and we have a high iteration frequency for testing ideas, to really make sure that we stay innovative, but that we're also far-reaching, that we're not shooting past the target. So when you think about design thinking, excuse me, and how it can help you, right? It's really it's giving you like a toolbox for tackling complex challenges. It gives you a structured approach to innovation, and basically as you go into fields that have not been walked on a lot before, it gives you an ability to really come up with a methodology that help you explore these new territories, new markets and technologies. So really it is about bringing three things together. Firstly, evolving around people's needs, products that evolve around people's needs. And I think this is especially important in healthcare, yeah, that we're actually addressing a need. Then is it feasible? And at the end of the day, if you're thinking, that there's pro bono work, but at the end of the day, in order to make an app that has a significant impact, it needs to return some investment, right? So at the end of the day, it needs to be profitable, and it potentially in order to make it viable. So with that, the design thinking is actually a pretty straightforward approach. You have a discovery phase where you identify the problem space. This is engaging more efficiently with your customers, or in our case, customers, but essentially whoever the end users might be of the technology you're developing. Gathering insights and also having a sharing of insights across multiple projects that may have similarities. And then this is about gaining confidence to really make sure and iterate through this. What does the customer really need? And then comes the delivery space. This is the solution space. So you begin prototyping, you begin testing, and then you iterate through this again. So we keep bouncing left and right between the solution space and problem space. It's not a snapshot at the very beginning, and then we jump into solution space, but we iterate back and forth between solution space and problem space in order to create meaningful outcomes. So hopefully a successful one at the end of it. Maybe one practical example on what we do in this space to give you some plasticity around it. We have these challenges along the patient pathway. I spoke about the imaging value chain before. There's a lot of uncertainty, complexity. There's inconsistency of data. There's proprietary formats. All of this disrupts the imaging value chain, makes this broken record. So it's about addressing this. So we've come up with a solution which is called Syngo Carbon, and that looks to connect all imaging disciplines into one. And imaging is a relatively wide term, that can also include ECG data, pathology data, cardiology data. So all these diagnostic services that come in. And really then by bringing this all together, you can leverage the toolboxes that are lying underneath. such as language models, such as AI, in order to really help drive outcomes. So with that, I pause my session and back over to you, Ian.
Thank you. Thanks very much. So now, Dragon, people have been people will post questions into the chat. Is that how you imagine we will do?
Yes, yeah. If people can just pop into the Q&A or even the chat, and we'll record that, and I'll send them through to you, Ian, and we can.
No problem. No problem. So if I could just ask a question just to start off with. I was fascinated with your commenting when you started off, Ben, about the broken record, where you talked about, you have a particular health case, cancer case in the family, but things just aren't connected well enough yet, despite, I don't know, decades of trying to get it to work, to connect better. And I posted recently something promoting an international conference where I said, my experience, my grey hair is because I've been in this area too long, perhaps, or lack of hair. My experience is that in health informatics, you can get the experience where I said 1 + 1 can be greater than 2. Well, what does that mean? You can get really clever computer scientists and technology working with health professionals, clinicians together. You can get better outcomes. If you work separately, it doesn't kind of. So I'm interested in any of you making comments about how do we deal with the problem that Ben's just talked about, where despite all of the things and Australia's Digital Health Agency or whatever, things just aren't connected well enough yet. What do we need to do?
If I can start a little bit,
Yeah, go sharp.
I've got a neighbor who is now working in the States, and he is on a diabetic medication, which is a relatively new one, expensive, and the insurance companies doesn't cover it. So he actually, every 6 months, he flies to Malaysia or to Thailand and collects and gets 6 months worth of medication and flies back. And that is cheaper. The flight cost is covered, a 5-day hotel, 5-star hotel cost is covered, and he can play a lot of golf in between as well. And still he comes off better, and this is in an environment where you order something, you order a computer or something online, and it arrives on your table the very next day from China or Taiwan or wherever, and this is an environment where, this environment where you can do that, but to get some medication which is not covered, which is cheaper elsewhere, is so much of sort of discrepancy in the cost, and that's a major driver of lack of equity. And this democratization we are talking about is another issue there, you see. So it is much more than, and when he goes back to the States, when he declares it to customs, they get a little bit upset, I mean, 6 months worth of medication, for God's sake, kind of thing. Many people go to the Canada and get it, but flying to Malaysia or Thailand is actually cheaper to get the same medication at the same sort of original drugs. So something very simple like that, we're still struggling, where we have the resources, where we have the ability, we have the technology, and we have the infrastructure to send things across the world within 24, 48 hours, but we can't do it for something simple like that. Large numbers of UK sort of patients will come to India or to Malaysia and get a bypass done, because it's faster, quicker, and cheaper at the end of the day as well. So this kind of things are major discrepancies, which you would think that in this day and age, we'll be able to sort it out.
Ben or Maitri, any other thoughts from you?
Yeah, look,
how do we sort these things out? Is the future positive?
I completely agree with the other speakers. In terms of, from my perspective as someone who thinks about health systems, I think one of the issues that we sometimes have when we think about digital health is that we think about it as merely a technology. and we forget some of the other aspects of the health system that need to be present and functioning well in order for that technology to work effectively. So, Paul Palmer used to be, who was a global health professor, used to talk about the 4 S's of health systems, which is, stuff, staff, spaces, and systems. And I think it's useful for us to think about when we're thinking about any aspect within that system. In order for that to work, you need to have the staff, you need to have the workforce, you need to have the spaces, you need to have the systems in place in order for that technology to function. So an example would be, I was talking about this, the electronic medical record within the prisons. Everything's suddenly become online, which is fantastic. But then there are still aspects where they have asked us to print certain things. And if the message that goes from the computer to the printer isn't working, as it has happened a couple of months ago, it turns everything into chaos because nobody knows what to do, and then everybody's phoning. No one knows who to phone, and so it is that issue where sometimes we've come to this very advanced stage, but we forget sometimes that those technologies have to be embedded in strong systems in order for them to work well.
Okay. Ben, did you want to add anything? Go ahead.
Yes. If I may, I think one of the key aspects to this is really a health information exchange. There might be multiple carriers on how data are exchanged between places. That might be the patient being the carrier, that might be internet-based connections, sharing between institutions, because the patients visit different institutions. And at the end of the day, someone needs to recognize that there is a common good there that requires a certain level of investment. And there's also then regulations that dictate on how data can be shared or can't be shared. So I guess it always bounces back to, what is an economical way of really doing this in a way that is also compliant with regulations and adheres to cybersecurity, so the data don't get shared in a way that's unintended. So I think if these two topics come together, an economical way of sharing data, health information exchange, then data can flow and that the record might not be broken any longer.
Fantastic. So thank you. I've got a question here from Hurley in the chat. How do all categories of clinical staff participate and become an active working team member in digital health, whether it's in the public health sector or in private clinics? How do we get the diverse cadres of health professionals working together? So whether it's Maitri or Shah who are working in the health system, or Ben, how do we can we get this to work?
Well, I mean, just that's a great question, and I think there's to my mind, there's a few aspects of that. The first is ensuring that we're creating an equitable level of health literacy, digital health literacy, and that's much easier said than done, especially when we're dealing with often a hierarchical system in health systems anyway, where certain members of the health staff will receive more education, more literacy around certain things anyway. So I think, there needs to be a far deeper dive into what digital health literacy actually looks like and what level is required to create equitable access for all members of health staff.
Yep. Any other thoughts?
I think it's at the end of the day, you can only communicate, as Benjamin has indicated as well, that you can only communicate when and integrate and work together if you're often using somewhat the common systems or systems which talk to each other, and that's where our problem is at the moment, especially in the private and public sectors. they are quite different. The systems in public, you can say perhaps the government can sort of put some regulations to indicate that we all use a certain system. Let's agree on something, and then we all use the same common hospital management system or communication system, which is open to patients, whatever. Whereas, because at the end of the day, the government pays. Whereas in a private sector, that's often a problem, isn't it? They are entirely separate. They can choose anything they like, and often there is. I mean, I don't want to be too cynical here, but there is often a sense that non-communication is often good for business as well. In the sense that you can actually there's the common good is not the primary criteria for a private business to work. So in that sense, I think it is important to make sure that there's some regulations where we all agree and we use common systems, which becomes available to patients and then to other healthcare practitioners.
If I can just add as well, and you might want to add your thoughts too, Dragan, but we've been running the course on digital health for some time, and we've had, I've had the enjoyment of having a diverse group of people. And so I've had clinicians, physiotherapists, social workers, quite a different cadre, both in the public and the private sector. And what's been fascinating is we have roundtable discussions, and most of them can see how it could be applied in different ways in the work in which they're in the place in which they're working. Obviously, slightly not everyone's a doctor, but the others can say, oh, I could actually use the digital health technology, or at least this one, in the workplace I'm working. Actually, another one was a vet. I was talking about how some things are being developed in the veterinary area where you can use digital health to improve their care for dogs, for example. I hadn't thought of that, but Dragan, do you have any thoughts as well on this issue?
No, well, I was just going to pick up and I guess throw to the panel. As an educator, the last 6 weeks of my life has been consumed by ChatGPT, and you mentioned Chat4 and whatnot. We've always struggled with health literacy, I guess, patient literacy. Where do you see sort of those AI sort of advances, particularly Martha and Sharon in the clinic? Do you see that, I guess, closing the digital divide or widening it?
I think it remains to be.
Yep. Go ahead.
I think it remains to be borne out in terms of, because it's so new, and certainly at the moment I'm still sort of on the other side of just kind of trying to hold back the tide of Google, Dr. Google, every day. Just kind of it's becoming a really insidious problem, actually, that people. I had a patient that I prescribed something to. I was talking to them about a new diagnosis of diabetes the other day, and they had gone home and read all of this stuff on a social media site, came back and was telling me all about this. And I said, oh, look, that's not really what we see from the evidence. And he said, well, you haven't read what I've read. So within the last 24 hours, that was it. So it really will be interesting to see how ChatGPT will do that, because my understanding is that it's not referenced. We don't really know necessarily where some of that information is coming from. And depending on who is in charge of that particular technology, how that can, I can see the potential for education, but I can also see a potential for some disinformation as well.
I think Shah mentioned a bit. Go ahead, Shah. I was going to say, you mentioned earlier the transition from Professor Google now into whatever, ChatGPT 4 or whatever. Over to you, Shah.
No. I think ChatGPT is similar to Dragan. I've been consumed by this ChatGPT business as well. And we are sort of worrying about how students will just, assignments are all ChatGPT stuff, from now onwards. They're going to go to ChatGPT and all the assignments They don't actually look the same, even though you put in the same question. So it's very, we're looking at, this is going to change and make our assessment so much more difficult. So we've been talking about that. But as I had sort of alluded to a little bit earlier, all new technologies, as people, we tend to look at the negative aspects of it. ChatGPT has got a lot of problems. No one is arguing with that. But the GPT-4 seems to be slightly better. What about 3 years down the line, ChatGPT 9 or something? What happens then? That is definitely going to be better than the one ChatGPT 3 for sure. And at some point, it's going to reach a stage when it's going to be better than humans, so to speak. Yesterday there's this almost 1,000 experts, sort of organized by Elon Musk, writing a note saying that, we should all put all this ChatGPT at a pause. I don't know whether anybody has seen it or not. 6 months, we should pause all this AI business while we sort of identify where the problems are and get some regulations sorted out. This was literally yesterday, So you can see that people are worried, but like a lot of things, I think it is something that we can't stop and is probably going to get better. And all these kinks and these things will get better as well. So I am like Maitri, I'm not sure where it's going to go, but a lot of these new things eventually will become something that you can't live without. And I think that's going to happen whether we like it or not.
I can just add a comment there and then I'll flick to you, Ben, because it's relevant to your area. Obviously, I'm in an education space as well, and there's always this discussion. So I had a discussion the other day, and I said, well, I've been interested for a long time in medical imaging, not that I'm and I said, there we talk about augmented intelligence rather than just artificial intelligence. What I mean by that, technology can help screen millions and millions of images and come and say to the clinician, I think you need to look at these. That's like matching the technology with a human to get the best outcome. Ben, where's this space taking us? This kind of idea of augmented.
Yeah, I think this is pretty hot. This is a hot topic at the moment. This is already pretty real, to be very honest. Mass screening. Like I said, right, this is addressing exactly the problem that we have more demand than we have supply in terms of health services. So I think this is an up and coming area. I just also wanted to put a positive spin on the GPT business. Not that it's not been consuming anyone, yeah. So I've also been quite consumed by it. But I think at the moment, I think it's still as experts, it's explaining to naive people what it can and can't do, yeah, outlining these limitations. But when you understand the limitations, yeah, there's so many, especially also in radiology, there's so many repetitive tasks when it comes to reporting, yeah. Yes, there's a bit of input from the physician, but there's a lot of repetition as well. And I think there, from a workload perspective, you read burnout statistics from radiologists or physicians in general. I think there's a lot of good work to be done with things like ChatGPT, even in the version that it's currently on.
Fantastic. Well, thanks very much. Perhaps if I can just say thank you to Shah and Maitri and Benjamin for being part of this webinar. Many questions have been raised. Inevitably, and I guess if we go to the course that we've been running for some years now, Dragon, these are the kind of things that we kind of wrestle with in our discussion groups and so on. I mean, there's material in the course, but thank you very much for participating. It's been a pleasure for me to be here, part of this. I'll hand over to Dragon.
Thanks so much, Ian. And just to wrap up, big thanks to yourself, Shah, Benjamin, and Maitri. And as Ian mentioned, just to get a plug in, we do have an upcoming version of our Fundamentals of Digital Health course registering soon and to be starting just after the Easter break. So we'll pop the URL in, but we'll also follow up with email. So if you are interested in exploring this space and having a chat with us and working through the materials, please feel free to register and get some more information. Otherwise, we look forward to hopefully seeing you sometime in the future. Once again, thank you very much, Ian. Thank you very much, Ben, Shah, and Maitri. And thanks to our participants for spending your lunchtime, or depending on where you are in the world, your morning or evening with us as well. Thanks all, and wishing you all the best moving forward.
Thanks, Greg.
Pleasure.
Bye for now.
Thank
Thank
you.
you, everyone.
you.
Enjoy
care.
the course.
Bye.
All right.